Research is the cornerstone of innovation in clinical practice, driving improvements in patient outcomes and shaping the future of medicine. Welcome to the Global Rhinology Network Topical Research Symposium. I'm Ashok Rokade from Winchester, UK, and it is my privilege to welcome you as a host. Joining me as co-hosts are Louise Melia from Bath, UK, and Professor Thibault Van Zele from Ghent, Belgium. This symposium showcases fascinating topics across 4 key modules: General Rhinology, COVID session, and Research in Chronic Rhinosinusitis. A special highlight is the PhD session featuring research conducted by enthusiastic young rhinologists who represent the future of our field. This symposium brings together leading global minds in rhinology who will highlight latest developments with a focus on translating research into impactful patient care. The Global Rhinology Network is dedicated to advancing knowledge innovation. Thank you for being part of this exciting journey. Thanks to Medtronic and Claus for their generous support in making this symposium possible. Welcome to GRN Topical Research Symposium.
And it's a privilege again to invite Professor Claus Bachert. He doesn't need introduction in the rhinology research sector for sure. He has played a pivotal role in bringing the clinical rhinology and the research rhinology, both the streams together. GRN has recently held a phase shift on his retirement from Ghent University in Belgium, which was the grand oration that he delivered was very well received worldwide. And we're really looking forward to hear from him about today's topic. He is working as a professor at Karolinska Institute in Sweden at the moment. He has contributed to more than 500 peer-reviewed journals, many book articles, and was instrumental in developing the guidelines, IPPOS guidelines and the area guidelines. So over to you, Claus. Welcome, and thank you for your presentation.
Thanks a lot. I hope you can see you can see my presentation. I just have to go to the presentation mode. So of course, with the colleagues being present here, I think I would probably not need to talk because you all know the studies and results, but I just want to give you a sort of an overview on a disease that chronic rhinosinusitis with nasal polyps, which was really a difficult to treat disease when I started my career. And that has been changed, and clearly from both sides, from the side of the surgery and also with, of course, the current biologics that are available. Just to bring you back that what we know, of course, there is this type 2 inflammation, and this is more the lower panel, but you can have type 2 inflammation in about 50% of CRS without nasal polyps. What we do not understand yet is why this is quite a mild to moderate type 2 inflammation. Why doesn't it form polyps, although some polypoid appearances were also described. In chronic rhinosinusitis with nasal polyps, 85% of that is actually type 2, at least in Europe, but also in the US. And that disease, of course, has been characterized as very persistent, recurrent, and very frequently also with comorbid asthma. So when we look at the comorbidity. I just told you there is asthma and aspirin sensitivity with it, but also that has an effect on how frequent these patients need follow-up surgery. So after the first surgery, there's a second or third or even more surgeries. Now, of course, we had that problem in the beginning, and we thought about different ways of treating or of dealing with this fact before the biologics actually came. One thing, of course, to define these patients is to create a definition. I have to admit that this definition is from 2020, although we thought about reboot surgery already before. But the definition says nowadays, if you talk about these patients, they should have a nasal polyp score of 4 or more at a certain time point, and they should be symptomatic. And this, although they have been treated with the classical treatments, topical glucocorticosteroids, maybe some courses of systemic corticosteroids, although we discourage the use of systemic steroids, certainly for longer periods and too much repeating every year. And then the patient does not react to classical treatment and still has to suffer from chronic rhinosinusitis with nasal polyposis, which is symptomatic. So that would be severe uncontrolled chronic rhinosinusitis. And most of these patients show up in our clinic with a history of some surgery before, which, of course, it's not quite clear what kind of surgery that was, but we work certainly on new ways of doing surgery here. Of course, what we know today is that this is a type 2 inflammation in the background, in the mucosa, everywhere in the mucosa. We did samples from all the different sinuses. It doesn't matter whether you look in maxillary or frontal sinus. You have this type of eosinophilic. In the first era, it was called eosinophilic. Nowadays, it's type 2 immune reaction, which involves the epithelium, which involves T cells, ILCs, but also sort of eosinophils and basophils and plasma cells. Actually, we currently did a single cell sequencing study, which we currently work on publishing. And the idea of that study tells us that there is not a single cell or a single cell type, even fibroblasts, which are not different in nasal polyps versus healthy mucosa. So it's really a very much bigger problem than just a few eosinophils or a deviated T cell cytokine pattern. At the moment, we call these type 2 chronic rhinosinusitis with nasal polyps because here we know that recurrences are quite frequent. A lot of these patients have asthma comorbidity. So how do we identify type 2? And the first question is very simple. You ask for comorbid asthma. If this patient has a comorbid asthma with nasal polyps, then very likely 94% of these patients are actually type 2. If that's not the case, or if that is the case, you can also look for blood eosinophils as a very simple blood marker. And if that's above 300 cells per microliter, you actually have confirmation of your type 2, and you increase the percentage of patients to 98%. If that's not the case, so you have no comorbid asthma, blood eosinophils is above 300, you still have 95% identification of type 2 in the tissue of the nasal polyp patients. Now, the other side is if the patient has no comorbid asthma and the blood eos are less than 300 within the last year, and that might be 2 or 3 samplings, then the chance that this is type 2 is about 50%. So we have quite a good measure to actually read type 2 in the clinic. without using biopsies from the nasal polyps. But of course, if the patient had former surgery and eosinophils are described, then this is already enough to show that this is a type 2 immune reaction in that specific patient. So how would we treat that? Of course, in principle, we have the possibility of surgery, and that has been described, and there was a lot of movement into endoscopic functional sinus surgery. And I had the impression that specifically for those patients with recurrent chronic rhinosinusitis with nasal polyps, that was maybe not the solution, and therefore created this reboot surgery, which actually is intended to take away the memory of the mucosa to form a type 2 immune reaction. On the other side, you have, of course, biologics, and these have been introduced more and more on anti-IL-5, dupilumab, and it's a double antibody. So these have been introduced, and the question was then, okay, for which patient, but also how could we potentially combine these different possibilities of treatment. Just shortly about the reboot approach. The reboot approach made the statement that there is a disease in all of the sinuses. And this mucosa has the possibility to form polyps. So there are two elements to it, the type 2 inflammation and the formation of polyps, whereas the nasal mucosa may be type 2, and we know that, of course, from allergies and other diseases that this is possible, but they do not form nasal polyps. The reason for that is another question we don't look at today. But the principle here is that if you want to avoid nasal polyps, you take away the mucosa that can make polyps, and that's especially the sinus mucosa. And with this reboot surgery, then we have shown that we had in our group better results with reboot than with non-reboot procedures, where the polyps were taken away and thickened mucosa, but not all the mucosa. On the other hand, of course, there was this idea that this would produce difficulties in the healing phase, but we have now results, observations over more than 5 years, more than 10 years actually, or nearly 10 years, and have seen that that normally heals. It's a very fast healing process, probably from the nose into the sinuses, and this mucosa does not relapse with polyps for a long time, and at the same time covers the sinus mucosa, sinus walls very fast, within 2 or 3 weeks. Here we have some data that we just evaluated recently with a colleague from Brazil who was very interested in smelling, and she did a lot of smell tests, and saw here that it takes some time, 3 to 6 months after the surgery, that actually you get your smell back. But those with endoscopic sinus surgery without reboot in our clinic, but with a different technique operated, had worse results on the long term over the next year than those with reboot surgery. Indicating that if you reboot, that means you exchange the mucosa by removing the diseased mucosa, that this would be the better approach also for smell, not just for recurrence. Nowadays, of course, we have biologics, and these are directed against omalizumab, dupilumab, which is an anti-alpha-4 receptor alpha, omalizumab against IgE, and then several ones that were in the development, not really further developed, like breslizumab, or further developed like mepolizumab. targeting the eosinophils via IL-5 and IL-5 receptor alpha. And this is, of course, the well-known Lancet paper on dupilumab showing that the nasal congestion score, but also the nasal polyp score, had a great reduction, a nasal polyp score of about 2 nasal polyp score points. So the patients came but down from 6, something to 8 to 4 by 2 points in average. Of course, here there are super responders where the polyps completely disappear, and there are also non-responders in this group, and this gives a sort of a mixed picture in terms of reaction. This is also translated into nasal congestion. That gets much better, and you can very nicely see that if you ask patients for nasal congestion, there's quite some placebo effect. If you ask them or you ask the doctor for the nasal polyp score, this is a much better measure to really identify treated versus non-treated patients. There was also a very fast onset of smell again, and that was really impressive. That just took 2 to 4 weeks to have smell again, measured by the UPSID score. A lot of patients really reported spontaneously without us asking them that they could smell again within just 4, sometimes 8 weeks, but mostly it was that time point. And they kept the smell also during the treatment. Quality of life as a consequence of less nasal congestion and, of course, the smell returning also was significantly changed and maintained under treatment and slowly relapsed at the end of the treatment in these studies. So, of course, we nowadays recommend continuous treatment with the monoclonal antibodies. What also was quite significant in that study, and I think that is something that needs to be translated to real-world studies, is a reduction in the need of oral glucocorticosteroid treatments or surgeries during this treatment period. But that is, I think, something that we will hear more from European registries and other registries in real-life situations in the future. Looking also at the lower airways, although these patients were not asthmatic or were comorbid asthmatic, not severe asthmatic, you also saw an effect on the FEV1 and the asthma control questionnaire in these patients. And of course, at the adverse event side, there was not much to see. It was quite a tolerable medication. In the meantime, we also have possibilities from other studies to treat with anti-IgE and anti-IL-5 or IL-5 receptor alpha, so targeting the IgE and understanding the role of IgE in the nasal polyps, and on the other side, the role of the eosinophil by antagonizing IL-5 and IL-5 receptor alpha. And what you can see here is there's also with omalizumab, which is the anti-IgE approach, in the Polyp 1 and Polyp 2 studies, there's a repeated fast onset also within 4 to 8 weeks in the nasal polyp score and the nasal congestion score. However, if you look at the data in comparison to what you saw with dupilumab, the delta is smaller. That, of course, is a question of whether you can still use these monoclonal antibodies in combination with surgery, for example. And that is not very important to realize, or whether it is important specifically if you rely on biologics only. And finally, there is mepolizumab, a study, the Synapse studies showed in a similar group of patients, however, using median changes instead of mean changes. So there's a little bit of a trial and to make something different in the studies to make them not so obviously comparable. But I think we all understand, if you look at the numbers here, that there is an effect. There was a significant effect of mepolizumab on the nasal polyp score, but this effect is different in size. And also, if you look at the improvement over time, you see that it is obviously a slower change over time, specifically also if you look at the smell, which takes some time to react to the treatment. Here you have the sense of smell, and you remember that dupilumab was quite fast in the first 2-4 weeks. Here it certainly takes some more weeks until you have an effect on the smell score, and the difference in smell score also seems to be different. Also, mepolizumab reduced the need for sinonasal surgery. But of course, as it seems here, to a lower extent and somewhat slower. This is a bit of a weak parameter, because when is another surgery needed is one of the decisive criteria for that parameter. But of course, it's a consequence of the treatment success with the biologics and with the different biologics in these patients. So nowadays, I would say we do have made enormous progress in the last decade in treating chronic rhinosinusitis nasal polyposis. There is certainly the understanding of a more complete removal of the mucosa as one of the ways to approach this. And there is also on the other side the possibility of biologics. Now, of course, what you could make out of that in this treatment algorithm, which was recently published in Nature Reviews, you can see very nicely on the one side the biologics, and on the other side the surgery. And of course, what you could do if you are a surgeon, if you love surgery, for some reasons we don't need to detail, then you go for the surgery and spare the biologics to those patients who relapse, for example. If you are a non-surgeon, you could still treat these patients with biologics and wait until late to send them to the surgeon if that is insufficient. So there are now really much more than before different ways of approaching this disease, and what the impact of that is on the number of surgeries and the patients on long-term biologics, because that's the key here, long-term biologics for the rest of the life, probably to prevent nasal polyp regrowth, is something to be discussed. Thank you so much for your attention.
Thank you, Claus. That was excellent. That really opened a very important topic of role of biologics in management of CRS. So can I ask panel, any questions from the panelists?
Could I ask about the surgery, please? I noticed from one of your slides that the patients that had the reboot surgery plus the draft 3 seemed to do better overall than all the other groups. What is your approach with regards to the middle turbinates, for example? Do you think a complete nasalization with removal of middle turbinates is a benefit, or do you try and preserve the middle turbinates if you're thinking about reboot surgery?
Well, the point is, of course, that you meet the patient at a certain time point. Mostly these patients had surgery before, or the middle turbinate is just, dislocalized by the nasal polyps to the middle turbinate, maybe already adherent there. So sometimes you cannot do much about what you find. I would always, if it's technically possible and the middle turbinate is preserved, I would certainly go for preserving further the middle turbinate and not removing it, as long as there is a bony structure that holds it in place. Otherwise, it's very hard to do something with it. But I would go that way.
Thank you.
It's better for the smell and also for the ventilation and drainage of the sinuses, as we believe.
Claus, you said in your talk that we would probably look into a combination of surgery and a biological. What is your look into the future? Should we pre-treat our patients with a biologic? Should we do surgery and then a biologic? And do you have any preference above the biologicals that we have at this moment?
Yeah, I mean, the point is really looking patient by patient. If you have the patient first time in front of you, you would certainly talk about the different ways of treatment that are possible. Actually, you are obliged to do that, and you would have to say, well, there's biologics, and here are the different possibilities, and on the other hand, there's surgery. In those patients who had surgery, and you also talk about a biologic, they tend to be more positive for biologics in the first place because they try to experience something else than another surgery. So you have also patients, who had a very successful surgery 10, 15 years ago, and they had no complaints or not much over a long time, and they would like to have the same effect again instead of all the time taking biologics. So you have really different groups of patients with totally different ways. What was your second question?
Well, if we should pre-treat our patients with the biologic before surgery, or we should use the biologic after the surgery? Yeah.
First of all, 60% of these patients have asthma. That's also something that we should not forget. Some of these patients are biologic patients from their severe asthma. If they don't have severe asthma, of course, I think it increases the argument for biologics in these patients. If you have a patient where you think that biologics might be a possibility at the moment, or the surgery on the long run might not do the job, then you should start with a biologic. Why? Because you need to see the response to the biologic. And for that, you need polyps. So only if you have polyp disease, you can treat with a biologic, confirm that the patient responds to that specific biologic, and the response rate for some of the biologics are between 50 and 85%. So you can easily have non-responders. So you first make sure that you have a responder, then you can decide on the surgery, and then if these polyps still recur after the surgery, that you have a treatment.
Okay, thank you.
Claus, what is in your definition of optimum surgical management, and what will you class as a radical surgery before you consider biologics in these patients?
The one thing is that there is all sorts of words here. Radical, extended. I would use the word complete, because we don't want to go outside the frame of the sinus walls. That I would call maybe radical or extended, but that's not the purpose. It's really a mucosal disease. So you